I can go live.
Yes.
Hello, good afternoon, doctors. Welcome to this webinar on influenza and its prevention. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar and welcome our speakers, Dr. Sainath Pawar and Dr. Swati Shrotri. Dr. Swati Shrotri is MBBS DCH MD Pediatrics. Madam is consulting pediatrician and neonatologist since 1996 at Datta Kashi Hospital, Satara. Passed with distinction fellowship and diploma in child adolescent disease. Passed diploma in child nutrition from Boston University, USA. Madam is director and founder Chirayu Hospital, Chirayu Children's Hospital, Satara Life Member IMA. Madam is life member of Indian Association of Pediatricians, life member of National Neurologist Forum, India Life member, Infectious Disease of Pediatrics. Dr. Shruti has served and arranged many free camps in and around Satara and has participated in free camps at Lokabedri Prakalpa Hemalkasa and at Surge Gadchiroli district of Maharashtra. Welcome, Dr. Shruti. Then the other speaker that we have, Dr. Sainath Pawar. Sir is MBBS MD Pediatrics and DCH FCPS, fellow in allergy and asthma from University Hospital of Leicester, UK, certified pediatric flexible bronchoscopist by APPS and IAP. Dr. Pawar is consulting pediatrician and pediatric pulmonologist and consulting allergy and asthma specialist, President Kolhapur Academy of Pediatrics 2024, National Trainer for NTEP IAP Action Plan, National Trainer for Pulmostar IAP Module, National Trainer for IAP REAP Module, Executive Board Member for Maharashtra Respiratory Chapter of IAP. Welcome both Dr. Pawar and Dr. A brief about Hetero Healthcare. We are an innovative pharmaceutical company with 30 years of excellence and 300 plus products in our portfolio. We have got 21,000 employees globally and our presence in 126 plus countries. We have got Asia's largest API manufacturing facilities as Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India. We have a wide product range which encompasses multiple specialties, pioneering in quality and innovation, and we have a distinction of bringing 4 biosimilar products to market within 5 years of launch. They are darbepoetin alpha, rituximab, bevacizumab, adalimumab. During COVID-19 pandemic era, Hetero Healthcare introduced antivirals like favipiravir, remdesivir, and oseltamivir. We are the pioneers in antivirals. In 2020, Hetero Healthcare received an award for pharma excellence for COVID drugs. Was awarded to Hetero Healthcare for their contribution in COVID drugs. With this brief introduction about Hetero, I welcome both the speakers, Dr. Pawar and Dr. Shruti, and over to Dr. Pawar for this session for further deliberations. Thank you.
Thank you, sir. Thank you for the kind introduction, and thank you, madam, for being here. So I'll share my screen. So, uh, so today's topic is like empiric use of oseltamivir in flu management, and so our contents are like one. So our contents are like healthcare challenges in monsoon and their diagnosis, influenza flu and its complication, clinical evidence of oseltamivir, and guideline recommendation for empiric use of oseltamivir. So basically, what are the key facts? So key facts are, if you see on the WHO website, there are around billion cases of seasonal influenza annually, including 3 to 5 million cases of severe illness. It causes around 2,90,000 to 6,50,000 respiratory deaths annually. 99% of deaths in children are under 5 years of age with influenza-related lower respiratory tract infection. These are in developing countries. And symptoms begin 1 to 4 days after infection and usually last around a week. So, healthcare related problem during monsoons. Like first is influenza-like illness, second is H1N1, third is severe acute respiratory illness that is called as SARI, and fourth is COVID-19. So what are there is one study which has studied about dynamics of the occurrence of the influenza in relation to the seasonal variation. The study was done in Chennai, Tamil Nadu. It was a 7-year cumulative study, and this was done by Department of Virology in 2019, and it is done in King Institute of Preventive Medicine and Research. So almost 36,670 specimens were subjected to influenza analysis, and the overall duration was 7 years. So, overall, the duration was 7 years, and they have seen that the influenza positivity started with the onset of monsoon and peaks during post-monsoon months. So this was the study which has shown that uh, the cases of influenza infection, this blue box is showing infection in 2015, so which was 4,259. This red box is showing 2018, which is 1,500 to 15,266, and the green box is showing 2019, which is 28,798. So these are the cases. Though how many were death? Here you can see that the blue box is showing 299. So that means the deaths in 2015 was 299. The red box is showing 2018 death, which is 1128, and the green box is showing death of 1218, that is in 2019. So you are saying that as the years are going by, the cases and death both are increasing. So incidence of influenza and related deaths increasing alarmingly in India. So that was this. So what are the symptoms of flu? As we know that we say in and out daily OPD, we see many patients with flu. And maybe today's OPD was havoc, so I think flu again increasing, maybe because of Diwali season or or whatever it is. But again, the patients are increasing. What are the symptoms of flu? First is fever, chills, body ache, cough, running nose, headache, sore throat, tiredness or weakness. We can say that feeling run down, diarrhea and vomiting only in the kids actually. So these are the common symptoms of flu. So according to this, we will just learn few cases, and these cases are our that we see in our day-to-day OPD and maybe sometimes in IPD also.
माझ्याकडे दिलं नाही माझ्याकडे का आला नाहीये आज पाठवलंय का आता तुम्ही होतीच नाही लागत माझ्या डेस्कवर एक एनवलप आहे.
Okay. So cases like this is the first case, which is a 2 years old girl child admitted with cough since 5 days, dry cough, hacking cough, cold since 4 days, which was running nose, fever since last 3 days, high grade fever intermittent. Child was little, heart rate was 125, respiratory rate of 35 minutes. Child was tachypneic, there was breathlessness. On RS examination, it was bilateral occasional cramps and rhonchi. Provisional diagnosis of that patient was LRTI with tachypnea or respiratory distress. Basic investigation was advised, which was HB of 11, WBC count of 11,500, lymphocytosis and platelet 2,46,000, and CRP was borderly raised, that is 9. X-ray has done, which is showing that X-ray is right hilar prominences with there is some patch on the right side, right mid zone to lower zone patch. So this was the X-ray. So we have labeled this case as lower respiratory tract infection. We have started the patient on antibiotics, started with nebulization. The mild tachypnea part settled with nebulization. But on day 3 of admission, patient has become drowsy, patient is sick looking, patient is not accepting food, and not very well looking child, sick looking child. So there was some fishy was means we thought that something is not right, and then we thought of H1N1 here, and we advised the H1N1 swab immediately. So we have done the swab, and after immediately sending the swab, we have started the patient on oseltamivir. Later on, the swab came positive actually. So as we have started on oseltamivir, patient was already on nebulization and antibiotic. But after starting oseltamivir, patient's sensorium improved, fever subsided, tachypnea was already lesser and still improved. So patient overall become better with good sensorium. and patient improved. So we have discharged this patient. So this was the lesson from this case. We can take that key. Maybe when the patient is having LRTI-like symptoms, we don't know whether it is bacterial, whether it is viral. But if the child is becoming drowsy, not responding to antibiotics, sensorium is deteriorating, please think of H1N1 and you please go accordingly. So we'll just discuss this and then I will ask madam. So whenever we are seeing any respiratory complaints in viral in OPD, so it is our duty to differentiate between viral and bacterial. So how do we differentiate? So when the viral, how do we viral start? Onset is like acute, but more gradual than bacterial. There is some similar history of viral infection in the family seen. In bacterial, there is high grade fever on day one of symptom. There is may not be many other patient because bacteria is a localized infection and it is so family member may not be affected. Cough is the predominant symptom in viral and less likely in bacterial. Cervical lymphadenopathy less often in the viral and more often in the uh, bacterial one because most of the bacterial infection will infect throat, tonsil, adenoids, and this throat area. So there may be a cervical lymph node which are tender. Associated symptoms like rhinorrhea, exanthema, voice change, diarrhea, conjunctivitis. This is more in the viral because viral is a multi-system affection and it will be more localized in bacterial. So less coryza and nasal symptom will be absent. Local examination, pharyngeal redness may be there, but in the bacterial infection, you will see exudate, purulent patchy tonsils, and obviously red throat. So, madam, do you want to add in anything on our first case? Any insights or any your experience in your OPD patients or something? Madam, you are mute. Madam, you are mute.
Sudden change in weather will aggravate the number of patients. That
Yes,
is
ma'am.
there.
Yes, sir.
Otherwise, same.
Yes, thank you, madam. So this is another case. First case we have seen a smaller child with 2 years age. This is a older child who is a 14 years old boy. There was no specific previous history of allergy, asthma or any comorbid condition previously. This patient came with low grade fever, sore throat and myalgia and sore throat for 7 days. So there was no history of breathlessness, vomiting or diarrhea. He was referred from another hospital and he has received their ceftriaxone and piperacillin tazobactam, but still child was not improving. Fever was persistent. So this was we had done a X-ray will show actually. So basically his vitals were pulse of 110 and BP was 110 by 70. Temperature was 100. On examination, respiratory examination, bronchial breathing, bilateral cracks, mainly in the inframammillary region. Mid-zone interstitial X-ray was done, which has shown the mid-zone interstitial infiltrates. And as the patient was not improving, I will show the X-ray here. So you can see bilateral both bilateral mid-zone infiltrates are seen here, and there is a significant involvement of both the lungs. So X-ray is affected. Patient is not showing any improvement after starting 2 antibiotics also. So we are thinking in terms of H1N1. So we have sent the nasopharyngeal swab also in this patient. And CRP was 10. Rest other system were normal. Laboratory evaluation revealed normal CBC, normal leukocyte count, LFT was normal, and X-ray we already seen. And the uh, we have sent the H1N1 swab also, so which came positive, and we have started treatment with oseltamivir and 75 milligram BD as almost is adult like 14 more than 50 kg child and adult like weight. So we have started him on adult dose 50 milligram BID for 5 days with paracetamol oral hydration and hand wash. And this is called as walking pneumonia actually. Means the patient, relatively stable patient who is coming with pneumonia, not very bad as compared to X-ray is bad, but patient is not that bad. So it is called as, we can say it, walking pneumonia, which suggests a viral infection. So we should think of viral infection in such patient. So as we have started on treatment, patient showed marked improvement. subsidence of the infiltrates on chest radiography compared with the radiography before receiving the oseltamivir. So slowly X-ray is also improved. So let us learn about influenza more. So this is the influenza, one of the most common infections. This is caused by influenza virus. It is highly contagious airborne disease that occurs in seasonal epidemics and manifests as an acute febrile illness. So it can cause mild illness also and severe illness also. And some serious outcome of flu infection can result in hospitalization that we have already seen in our cases. And sometimes it can cause death also. It should not happen, but you should be alert for everything. And this is a diagram of the this influenza A virus. And actually, depending on the surface proteins, there are surface proteins. There is hemagglutinin and neuraminidase. These are the two surface proteins which are present on the influenza virus, and they go on mutating actually. And depending on their nomenclature is given like H1N1, H3N2, H9N5. So this is depending on their surface proteins mutation, and this is the reason that every year they will change, and then vaccine will not work next year. So influenza A, B. So what are the types of influenza? A, B, and sorry. Influenza A, B, and C. So A causes frequent epidemic due to the minor antigenic variation, that is mutation, and periodic pandemic due to the major antigenic variation. Influenza B virus infects human and cause local epidemics. C is milder illness, and it can affect both human and swine. So currently circulated human subtypes are H1N1 and H3N2 influenza viruses. So how do you this influenza virus is transmitted? So if the patient, any patient who has got influenza virus, and basically it is transmitted through droplets, and it can transmit till 6 feet of distance. So if another person is there within 6 feet of distance, so this person can transmit that virus to that. And how it is transmitted? While he is coughing, while he is sneezing, while he is talking, the virus can go into air, and that air droplets can go to the patient. So, and that virus is inhaled into the person in contact, and that will be inhaled to the lungs. So people should stay away from the affected person. If there is some person with influenza or any viral infection, then he should stay away from the other person. He should stay home, and the children should not go to school. They should not go to the play with other children, because they can transmit that virus to the other children. So most healthy adults may be able to infect other people beginning when they start to infect 1 day before the symptoms and 5 to 7 days after the symptom. And in children, they can transmit the virus after 7 days also. So these are the 4 that we already discussed, that there are 4 major illnesses that happens in monsoon. That is H1N1, SARI, COVID-19, and influenza-like virus, influenza-like illness. So how do you differentiate between these 4? So influenza-like illness, so all the symptoms like fever, myalgia, cough, lack of energy, sore throat, this will be there in most of all of them, all 4. Breathlessness will be less likely in influenza-like illness, but other 3 may have breathlessness. Loss of smell, loss of taste was, as we know, that it is a characteristic of COVID-19, so it is present in COVID-19. Diarrhea, COVID-19, and other plus minus. Headache may be or may not be there in all of them. So it may be sometime there may or may not. So headache is a plus minus thing. So what are the emergency warning signs of flu sickness, and especially in the children? So whenever child is having fast breathing, that is tachypneic, maybe he has got difficulty in breathing, he has got cyanosis, that is bluish green, he is not able to take fluid, he is not able to eat, he is not waking up, he is not interacting, child is very irritable, he doesn't want to take up, he doesn't want to be held in hands. Flu-like symptoms, first it improves and again deteriorates. So biphasic pattern. So and fever with a rash. These are the signs that the child in children we should keep a watch. If these signs are there, then we should be alert that this patient may deteriorating, or he may become serious. He may require intensive care or something like that. Second important thing, that whenever we are talking about infants. So infants, the symptoms are little different, that the child is not able to accept the feed. Child has got tachypnea. There is no tears because child is so dehydrated that he cannot produce the tear, and the urine output is less. So these features in infants, again, it is a warning signs for us. So what are the complications of flu? So first is pneumonia, second is bronchitis, third is the ear infection, fourth is worsening of the existing disease of like asthma and COPD. So these patient asthma of COPD, we are going to discuss it later again. But asthma, allergy, COPD in adult and asthma allergy in children, they will have more problems with this year, more complications. ARDS is the one of the dreaded complication which we should be aware of, because if patient is going into ARDS, so we should be ready for everything. And the unwanted complication of death is also there. So again, who is at higher risk of complication? Again, as we have discussed, allergy asthma patient, because they will start with flu, but they may go into allergy asthma attack, they go into acute exacerbation, and they will have their exacerbation, and they will have different symptoms only. A normal flu will improve in 3 to 5 days, but this patient will not improve in 3 to 5 days. The second thing, any patient with chronic neurological disease like kidney, liver, neurological chronic disease, so these will have problems with flu. Juvenile diabetes may have a prolonged flu. Immunocompromised patient, maybe because of HIV, cancer therapy, immunosuppressive medications, may have a more complications of flu than the normal patient. Sickle cell disease is also one of the thing that we should keep in mind. Obesity, and those who are living in daycare centers for a long time, they are more prone for more complications. Then now we are turning towards management of influenza. So treatment of influenza, first is always supportive management, bed rest, adequate hydration, good fluid intake, cough suppression if required, because in generally pediatric, we do not use cough suppression. So very dry irritating cough, if it is there, you give the cough suppression. Then antipyretic, like most preferred is paracetamol, NSAID if required for myalgias, preferably avoided. So most of the patient will influenza recover 3 to 5 days, but malaise may persist for few days or weeks. Some patient may require IV hydration and other supportive management. So now let us talk about the antiviral drug. So first is neuraminidase inhibitors, and second is amantadine M2 ion channel blocker. So what is the neuraminidase inhibitor? They block the viral neuraminidase enzyme, which is critical in the releasing virus from the infected host cell. So they will stop the virion release, and these drugs are active against influenza A and B. The examples are oseltamivir and zanamivir. And here in another this group, they interfere with hydrogen ion channel activity of the influenza virus, thus blocking its entry into host cells. So here virions are blocked, and here the entry is blocked. And the examples are amantadine and rimantadine. Out of which drug we use, you know that it is the oseltamivir, which is available, and we are using it day in and out. So let us learn more about oseltamivir. So basically, it is a potent and selective inhibitors of the neuraminidase enzyme of the influenza virus A and B. It is a prodrug which is converted into oseltamivir carboxylase in the liver, and it acts on the actually the virus. So it inhibits influenza viral replication and its pathogenicity. It further prevents spread of the infection. It is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1 and H9N2 strains. So here, how does oseltamivir act? So in normal, these are the continued the viral replication, but when oseltamivir is given, it blocks the virion's site, and it prevents the virion replication, and it halts the viral replication. So this is the way the oseltamivir is acting. So it was the first neuraminidase inhibitor which was found. It is approved in more than 100 countries, and FDA, CDC, American Academy of Pediatrics, these all are approved oseltamivir in the pediatric children use for the treatment of influenza. So now let us learn about the doses. So first thing we'll learn about the proper treatment, which is disease treatment. So adult it is 75 milligram twice a daily. Children it depends on weight actually. So if it is less than 15 kg, 60 milligram per day divided into two doses. So that is 30 milligram per day. So it is around 2.5 ml per day. So 15 to 23 it is 90 milligram per day divided into two doses. In 23 to 40, 120 milligram per day divided into two doses, that is 60 milligram 2 days BD. And in more than 40 it is adult dose, that is 75 milligram BD. So in infants 2 weeks to less than 1 year, we can use on depending on the weight 3 milligram per kg. Okay. So now we are coming to the chemoprophylaxis. So chemoprophylaxis is recommended to whom? So it is recommended for community outbreaks, and seasonal and pre-exposure prophylaxis is up to 6 weeks. So if there is any patient in contact with the maybe any XYZ person, and second is the community outbreaks. So normal duration of the chemoprophylaxis is 6 weeks, and immunocompromised we can extend it to 12 weeks. So what is the dose of oseltamivir for the chemoprophylaxis? So adult it is 75. Generally it is half of the dose. Means normally we are giving BD dose. So it is OD dose and half dose OD. So 75 milligram once daily, 30 in children less than 15 kg, 30 milligram OD. 15 to 23, it is 45 milligram OD. 23 to 40 kg, 60 milligram OD. And more than 40, adult dose for 75 milligram OD. So this is the chemoprophylaxis. And one more important thing is that treatment with oseltamivir should be initiated within earliest, basically. It is always better to initiate within 48 hours of onset of symptom. That is first thing. Second thing, but if you are not able to start it, means patient has come to you late and it has already 3, 4, 5 days, but you are strongly suspecting H1N1, please start it, because whatever benefit of doubt we can give to the patient, we should give. So even if it is started late, it will act, but it will act best within next 48 hours. Second important thing that there is a 30 milligram capsule of Fetero is available, which the children who are able to swallow the capsule or they are able to take the capsule, they can take this 30 milligram capsule which is available from Hetero only. So now what are the benefits of empiric and early use of oseltamivir? So basically oseltamivir treatment reduces of influenza illness, reduces the lower respiratory tract complications or complaints, antibiotic use and hospitalization. So there was study done which has shown that the study was done in 3,564 subjects, and they have seen that in patient with influenza, oseltamivir treatment reduces antibiotic use by 26.7%, lower respiratory tract complaints by 55%, and hospitalization by around 60%. So reducing occurrence and severity of the pneumonia due to the H1N1 by early oseltamivir administration. So this is a study done on 442 patients, and the median time of symptoms onset to oseltamivir admission was 5 days. So subjects were divided into four groups, like is less than 2, means when oseltamivir was started to those patients, less than 2 days early oseltamivir administration, 3 to 7 days, 8 to 14 days, and more than 14 days. So what was seen that both the probability of the severe pneumonia and probability of any severity of pneumonia, so this increased gradually with the time of symptom onset to oseltamivir administration. So if you start early, the pneumonia and severe pneumonia is less. If you start later, the pneumonia and severe pneumonia are more. Again, the second thing which already we have discussed, earlier initiation of the oseltamivir will significantly reduce occurrence and severity of the pneumonia, and it also shorten the hospitalization due to the pandemic H1N1. The second thing which we already discussed, even if you administer after 48 hours, it has shown the considerable potential for reducing pneumonia. So even if it is late, please don't say that it is already late and there is no use of giving it. Please give it. Whatever benefit the patient has to get, we will get. So again, patient with oseltamivir has got shortened time. Those who are given oseltamivir early were discharged earlier from the hospital. So there was another study which has done with oseltamivir and azithromycin. So the combination therapy, what was the motto behind it? We should try to avoid the secondary infection. So the group, what they have shown that this is a graph. This red is with only oseltamivir, and this is showing incidence of the secondary bacterial infection, and blue one with this blue one with oseltamivir alone and red one with combination of oseltamivir and azithromycin. So incidence is higher with oseltamivir and lesser in the secondary complications is lesser with the combination group. Here we can see that those patients who has required incidence of the respiratory support is higher in only oseltamivir group and lesser in the combination group. So basically combined treatment offers significant reduction in the incidence of the secondary bacterial infection and required less respiratory support. So it is recommended. Basically, you can combine azithromycin with oseltamivir. It also reduces treatment, offers significant reduction in the hospital stay and influenza symptom severity score. So you can see here the red one is less and blue one is more. So these are hospital stay and this is the severity score. So guideline recommendation. So what are the WHO recommendations? Empiric treatment is strongly recommended when you are strongly suspecting H1N1. Treatment should be started as early as possible. Laboratory confirmation is not necessary. If it is not available, you cannot do, patient is not affording, you give the benefit of doubt and start the treatment. Negative laboratory test, that is H1 for H1N1, does not exclude. Means sometimes it may be wrong technique of collecting swab or maybe many things like the transport may not be appropriate, the transport time may not be appropriate. So even if you are strongly suspecting clinical suspicion of the H1N1, please treat even if the laboratory test is negative, because there are many fallacies of the test. If the higher risk individual have exposed to the patient with influenza, you consider presumptive treatment with oseltamivir. So, and early empiric supportive treatment and monitoring. So you can give early antimicrobials to treat all the likely pathogen causing SARI, severe acute respiratory illness. The antibiotic choice will depend on your experience, your area, which organism you are seeing, and depending on age of the patient. Empirical antibiotic treatment should be based on the clinical diagnosis, whether it is community acquired, whether it is health care associated pneumonia, whether it is happened in healthcare associated settings, or whether it is sepsis. So empirically therapy should include neuraminidase inhibitor for treatment of influenza when there is local circulation or other high risk factors, including travel history and exposure to the animal influenza viruses. So overall, in summary, we can say that proper diagnosis can and early treatment can prevent the flu complication. Empiric use of oseltamivir reduce the lower respiratory tract complication, hospitalization, and antibiotic use. WHO American Thoracic Society recommends empiric use of oseltamivir when it is strongly suspected. So thank you. So, madam, do you want to add anything?
Madam, your experience on oseltamivir.
Oseltamivir is good. Sometimes it is late to start oseltamivir, but still, even if we start later, then improvement is there. Only if there is secondary infection, then it is commonly gram positive. And then higher antibiotics, sometimes we have to start if there is secondary infection.
But how do you decide to start an antibiotic?
In spite of suspecting virus, the count is on the higher side.
Okay.
And previously, it is history that patient was not that much toxic, but now becoming toxic.
Okay.
That
So
is
both clinical and laboratory diagnosis collaborate there.
Yes.
And how common is atypical infection in children?
It is common because children usually come in contact with adults and they have pharyngeal transmission, and then atypical is common.
Like mycoplasma, legionella, etc.
Yes, mycoplasma.
Thank you, Dr. Pawar, Dr. Shrotri. Thank you
Thank
very
you,
much
Yes,
for your
nice
insights.
presentation.
Yes, thank
Yes,
you.
thank you, madam.
Yes, thanks for your
Thank you.
insights. Thank you, doctors, for taking your time from a busy schedule and attending this. Thank you, marketing team Hetero, for conceptualizing this webinar. Thank all the field personnel of Hetero for super coordination to make this event successful. And last but not the least, thank you IT team for your IT support. Thank you all of you. Wish you a very pleasant evening and signing off. Thank you.
Yes, thank
Thank you.
And wish you happy Diwali to both of you.
Yes. Thank you and same to you.
Happy Diwali, Giridhar.
Thank you. Thank you.
मॅडम या तुम्ही म्यूट वर आहात. हा, नेक्स्ट डेट्स लाईक उद्याचं जे आहे ना, तो वी आर
हा.
नॉट प्लॅनिंग फॉर टुमॉरोज वेबिनार.